Good day, and welcome to the fifth in a series of presentations on difficult-to-diagnose cases of patients who underwent MCG testing and the effects that accurate early detection had upon their lives. Today, we are discussing a 54-year-old woman that went through a 3-year process of diagnosing and monitoring using our technology. The purpose of this video is twofold. First, as always, is to train and onboard physicians to better understand how best to use MCG to initially diagnose and then subsequently monitor patients. Today's case is a 54-year-old woman with dextrocardia. She's a patient with a family history of CAD, with her father having died of an MI before 60, along with other chest pain symptoms. She had atypical pains on her neck and upper back, and after having had an MCG exam performed on her, she was put through a cardiac magnetic resonance perfusion test, which showed decreased subendocardial signals in all 3 coronary territories, and differential diagnosis including reversible ischemic disease versus 3-vessel obstructive disease. At this point, a cardiac angiogram was suggested, and a subsequent catheterization report showed 30 to 40% proximal LAD, 30 to 40% proximal LCX, lesions, and right coronary artery dominance with luminal irregularities, which are small, non-obstructive lesions. At this point, an intensive dietary and lifestyle intervention was initiated. MCG correctly identified a pattern that more expensive and invasive techniques subsequently verified. In comparison, the very costly and generally inaccessible cardiac magnetic resonance perfusion test overestimated her coronary disease. Not only that, an MRI that was performed on her delivered false positive results, necessitating an invasive and potentially harmful coronary angiography. Secondly, as stated in previous videos, we would like to also demonstrate how MCG diagnosis works behind the scenes to deliver measurable mathematic expressions that are both clinically relevant and can be visually expressed, to better understand the cardiovascular system and its complex functions. We will be brushing over some of the details of the mathematical functions used by our diagnosis engine, but this information can be found in our primer and the recently published chapter in the textbook Personalized Precision Cardiovascular Medicine, an integrative, metabolic, and functional cardiovascular medicine approach, which should be reviewed first before watching this video series. The following is an outline of her journey. Her initial MCG session scores on a disease severity scale ranging from 0 to 22 were recorded as 4, 7, 7, and 7, placing her in category E, then a 9, 10, 7, 9, and an 8, placing her in category G, with indications of predominantly local ischemia, which occasionally alternated into global favoring non-obstructive patterns, with occasional higher flare-ups of obstructive CAD ischemia episodes. The second marker showed positive for cardiomyopathy, atrial fibrillation, myocardial damage, myocardial inflammation/myocarditis. Myocardial compliance was decreased in all tests, indicating chronic structural changes. The acute power failure and the global asynchrony immediately following the tests that scored a 10 and a 9 indicate a highly probable surge of ischemic burden during testing due to dynamic plaque remodeling/rupturing, and probably later followed by plaque burden reduction. The study was interpreted as consistent with non-obstructive disease, predominantly in the left anterior descending/circumflex distribution, but we could not exclude diffuse disease. In contrast to MCG testing results, again, the very costly cardiac magnetic resonance overestimated the disease burden and sent her for a coronary angiogram, which unnecessarily exposed her to contrast material and other risks associated with the procedure. That said, her dynamic plaque remodeling/rupture did indeed occur at bedside while tested on MCG. Thankfully, it resolved on its own, probably due to the intense lifestyle modification efforts she underwent, but it's important to note that MCG was capable of detecting all these events with far more accuracy than some of the most expensive tests out there. She was tested twice in 2 years after the first round of testing. The first showed that she scored an 11, 11, 8, 7, and an 8. A year after that, the subsequent session reported scores of 5.5, 7.5, 5.5, and a final score of 9. Her first test session was rated a G in our 8 categories rating for myocardial dysfunctions, i.e. high myocardial dysfunction with greatly increased propensity to worsen to a potential acute heart failure, or a major adverse cardiac event, also known as MACE. However, the second session was rated a category F, which is an incremental improvement. Additionally, the reproducible local ischemia initially settled from alternating between local and global to a functional pattern, and the acute power failure began to show some improvements. That said, congenital anomalies, pulmonary heart, persistent decreased myocardial compliance, and left-sided favoring global asynchrony remained, likely contributing to the high disease severity scoring, thus reducing the share of her CAD disease burden. Something significant to note here is that many of the noted fibrillation and arrhythmias detected reproducibly pointed to her condition being more chronic. While these sessions showed incremental improvements, more follow-ups were pursued to track her progress with her treatments. She was monitored every 4 months in 2019, starting from her Category G in 2017 and falling down and settling to a Category E. That said, something new occurred. As myocarditis and inflammation became more frequent and persistent, a newly detected decreased ejection fraction and an acute power failure indicated acute expressions of what were now known to be ongoing chronic conditions pointing towards the possibility of heart failure. Thankfully, these have been detected early enough and in time for treatments and additional measures to be taken to tame the inflammatory process and decreasing ejection fractions, likely improving her overall disease reversal strategy and deterring the march towards eventual heart failure in the long run. These are graphical representations of the autopower spectra measurements of both of the patient's sessions. We want to use these to demonstrate how the MCG analysis program understands the unique expressions of the cardiovascular system by breaking down the electrical signals of the heart into frequency bands that can be viewed and measured by the computer as such. From here, the analysis engine measures the peaks, trows, interpeak intervals, and overall power output represented by the area under the curve. The increasingly redistributed power peaks indicate generally that the power output of her cardiovascular system is becoming more evenly distributed compared to the previous power failure she was experiencing. This function, impulse response as described in previous videos, is useful for watching the system's response to internal or external stimulus. When increased, it may mean there is acute myocardial damage or myocarditis to ischemia. When decreased, it could indicate myocardial hypertrophy or increased stiffness of the myocardium due to hypertensive heart disease. For example, here, her MCG scores detect a persistent decreased compliance throughout her sessions. Her phase angle shift visualization can show that her heart's expressions are quite visually abnormal compared to previous cases in prior videos, showing significant shifts below the neutral line of the graph, which generally indicates dextrocardia. We believe that atrial fibrillation and other cardiac arrhythmias can be caused more often by functional ischemia and/or acute or chronic myocarditis, which can be expressed mathematically via this function. Cross-correlation provides many very useful measurements, focusing visually on the results generated and shown on the graph, where the last session showed a triangular wall of peaks. The treatment's results can be seen visually when compared to a more normal pattern that is easier to assess. The initial supply and demand imbalance patterns were probably the cause of her chest pain and some acute ischemia occurrences. The transfer function can serve as a bridge to move from one functional environment to another. The differences between the pre- and post-treatment measurements are again visible, though more subtly than usual. Meanwhile, these colored heat maps of the multiple functions are very useful not only for visualization of the mathematical output, but also being gateways to better machine learning color matrices for pattern recognition and disease severity calculation, along with providing early warning of sudden cardiac death. And finally, these mathematical structural element matrices collect the results of these functions described previously to create the patterns that you see here in a transparent and reproducible manner that the system then uses as the neurons for its analysis engine. The majority of the time, using conventional diagnostic imaging tools, the diagnosis of intermediate stages of functional ischemia in women is nearly impossible, very time-consuming and costly. This is why more women die from ischemic heart disease than men, because the diagnosis usually comes too little too late. This case example shows a woman with not only cardiovascular system issues, but specifically with dextrocardia. It's a relatively rare congenital anomaly that only adds exponential difficulty to making accurate diagnosis, even with the costly tools such as cardiac magnetic resonance perfusion tests, only available in world-class teaching hospitals like the Columbia University Medical Center. Even then, her diagnosis by the cardiac MR was still incorrect, sending her to an unnecessary and invasive coronary angiography. This in comparison to MCG, which was capable of making her diagnosis early and demonstrated its capabilities in hunting down and identifying even the most difficult to diagnose case. The tracking of the reversal of her initial findings, mainly her metabolic component of her ischemic heart disease following simple lifestyle improvements, is easily managed at her bedside without the need for coronary interventions thanks to our device. MCG can be a very effective tool for accurate diagnosis and monitoring of the effects of primary lifestyle modification and prevention safely at bedside for women, even those with complicated congenital heart anomalies that would cause other modalities to fail. I hope this presentation has proved useful in better understanding some of how our system performs its diagnosis to save lives and cut costs for patients and doctors alike. If you have any questions, feel free to visit our website or send an email to info@premierheart.com and have a wonderful day. Thank you for your time.